Good evening and welcome to the Wayland Library virtually. Tonight we're excited to have Fatima Amir here to talk about genetic testing for hereditary cancer risk. Fatima has been a genetic counselor at the Dana-Farber Cancer Institute since 2018, where she provides cancer genetic counseling to adult patients. She has a special interest in improving access to genetic counseling services among medically underserved populations. She received her master's in medical genetics from the University of Cincinnati and Cincinnati Children's Hospital in 2018 and was certified by the American Board of Genetic Counseling that same year. And one of the things I found so fascinating about Fatima when I met her, I had never heard of a genetic counselor. So hopefully we can talk to her about that. It's like a brand new field. But in the meantime, I have a couple Zoom housekeeping notes. I'm recording this session and it'll be broadcast on Waycam, which is the Wayland Cable Access station, and also available on YouTube, so you can share it with your friends. So you may see your tiny video picture on TV briefly, unless you turn off your video. And then during the slide portion of this program, which will be about 20 minutes, I recommend you switch your view to speaker view, and that way you'll see the slides and Fatima right next to each other. I'll also put this info in the Zoom chat. And finally, feel free to add your questions into the chat at any point, and we'll get to them at the end of the presentation. So now that that's over, I will hand it over. Welcome, Fatima.
Thank you so much, Courtney, and thank you everybody for making the time this evening to join us. I am very passionate about genetics, so I'm happy to leave a lot of room at the end to answer any of your questions, and hopefully you guys will all learn something helpful after today's talk. So this talk, I kind of like to give an overview of what it is that I'm going to be going over when we're talking about genetic testing for hereditary cancer risk. So, of course, it's going to be helpful to go over what does it mean to have hereditary cancer risk? What are some hereditary cancer clues? What do genetic counselors do, like Courtney mentioned? What is the purpose of cancer genetic testing? And then what is an example of a hereditary cancer syndrome? We can walk through that to help explain that a little bit better. And then, of course, we can answer, what does genetic testing involve? And of course, like I said, we'd love to leave lots of room at the end for your questions. So starting off, what does it mean to have hereditary cancer risk? So to answer that, I like to step back a little bit, maybe just do a little bit of a basic genetics review. So the way I like to explain this is our bodies are made up of billions and billions of cells. They're like the building blocks of our body. So some of you, this might be a throwback to your high school biology days, or you guys are probably trained even further in biology, and you can zone out for a little bit. But basically, inside our cells, we've got our genetic information. And the genetic information, you can think of it as being organized in the way an instruction manual might be organized. So just like in an instruction manual, you might expect to see chapters that make up the instruction manual. You might expect to see chromosomes that are like the chapters that organize our genetic information. And then just like if you open up a chapter in an instruction manual and it's made up of a bunch of words, our chromosomes or our chapters of our genetic information are organized by these genes. So our genes are like the words that make up the chapters or chromosomes for our genetic information. And our genes can then, of course, further be broken down into individual letters, just like words are broken down into individual letters. And those are the letters that you might see in the media when you see genetics being talked about, the ATGC letters. They're the basic 4 letter blocks that build up our genetic information. The genes are they're like recipes. They code for a food product, which if you think about it like a recipe, which in this case are usually proteins that go then do the physical functions that these genes are encoding for. Now, for some basics, we've got about 25,000 genes in each of our cells. So there's a lot of these. And each of these genes have different functions. They can range from telling our cells how to grow, how to develop. They might code for our eye color, our hair color, lots of different functions that they might have. what we are specifically interested in are looking at the cancer genes, or the cancer risk genes, which are the genes that are basically designed to protect our cells from becoming into a cancerous cell. So we all have these genes. And in fact, we have 2 copies of each of these genes. One copy that comes from each parent, so from our biological mother and our biological father. So this is just an example. Let's just say there's a gene called theater. Now, there isn't actually a gene called theater to my knowledge, but this is just an example of it spelled out. So this is an example of seeing, you know, there's one copy here from our mother, one copy here from our father of the gene theater, let's say. And let's say the job of this is to protect the cell from developing into a cancerous cell. Now, sometimes someone can be born with one of these copies of the gene being misspelled. So here's an example. Let's see, in one of the copies of this theater gene here, instead of an E in that 3rd letter position, there is now an X. And that loses the meaning then of the gene, because the gene's supposed to spell out theater, but now with an X, it doesn't really spell that out anymore. So it's kind of lost a little bit of its meaning there. And so one of the things that's exactly what we then call an inherited genetic mutation. It's kind of like a spelling error in our gene that causes that gene not to work properly. So just like kind of to break that down a little further, so you've got this inherited genetic mutation, one copy of your gene not working properly, which means if the purpose of this was to protect the cell from developing into a cancerous cell, now one of the copies not working means that you have an increased risk of developing cancer compared to the general population. And that is what we call hereditary cancer risk, is do you have an increased risk compared to the general population for developing cancer based on your genetic makeup from the time you were born. I always like to mention that having an increased risk of cancer is not equivalent to saying that you will develop cancer in your lifetime. So very, very rarely, are these gene changes or gene mutations actually translating to a near 100% risk. For the most part, overwhelmingly, they are just saying that there is an increased risk. And what that risk increase looks like is different depending on what gene we're looking at, depending on what cancer type we're looking at, can range from as small as a very, very low increased risk, where we might not even have a number to put for it. Maybe it might be a 5% risk lifetime, it might be a 10%, it might be a 50%, sometimes probably on the higher end, you might see something as high as an 80% lifetime risk. But that's different depending on what gene we're looking at and what cancer type we're looking at. Of course, knowing then this information can be very, very powerful, because that can then allow us to potentially, impact your care a little bit differently. So if we know about a certain risk you may have that's increased over the general population, we might decide to follow you a little bit differently than we would someone in the general population. I also like to clarify that most cancer is not hereditary. So what do I mean by that? So we'll kind of break it down a little bit further. Only about 5 to 10% of all the people who develop cancer in their lifetime, if we did genetic testing for them, would be found to have one of those inherited genetic mutations, which means that the vast majority of cancer is what we call sporadic, meaning it happens either just because there might be some type of exposure in the environment. Sometimes that can take the form of chemicals, radiation, some kind of exposure we might not know of. Sometimes lifestyle risk factors can increase the risk of cancer, such as, we think about smoking as being a common one. The aging process can sometimes be aging as a risk factor for developing cancer. And that's part of why I say nature isn't perfect. So our cells, every single day, they're making billions and billions of copies of our genetic information. The example I like to use is that of a Xerox machine. If you think about a Xerox machine needing to make billions of copies every day, it's bound to make an error. Now, of course, our cells are much better than Xerox machines, but they are similarly making a lot of copies of our genetic information. And in doing so, they're bound to sometimes just make an error in that process. And while there are mechanisms in place to protect, the cells still in that case and to correct those errors, sometimes those mechanisms are the ones that get a little faulty. And that's why we might see cancer a little bit more in older age than we do in younger people. Now, you might be noticing, if you have good observation skills, is that there is also another piece of the pie here, and that's called familial. So that is basically when we might see multiple people in the family who have cancers, but when we did genetic testing, we didn't quite find a genetic explanation for why they have cancer. And there's a couple of different possible explanations then. One possible explanation is that there could be genes we've just not discovered yet that could be explaining some of that family history of cancer. But we also know that there could just be potentially a shared environmental exposure. So maybe this family lives near a factory mill where they're all exposed to certain chemicals that increase their risk to develop cancer. So it's not necessarily that they actually were born with an increased risk of cancer, of developing cancer, but they might just have a shared environmental exposure that increases their risk. What we're trying to do with genetic testing, if I just go back here real quick, is to see if you fall in that 5 to 10% category, because that's where, you know, that information can help guide your care potentially. So what are some clues in a family? So this diagram you're seeing right here is what we call a pedigree, which is just a fancy way to say a family tree. And what you're kind of seeing here, just to kind of break it down a little bit, circles are the label used for biological females, squares are the label that is used for biological males. Anybody who's shaded in is meant to say that they have a cancer diagnosis, and underneath them you'll see the cancer type noted, as well as the age at which they were diagnosed. So some clues, when I'm meeting with people in a session, I typically draw out one of these family trees. And what we're looking for, the clues, some of the examples of clues we're looking for are when we're seeing more cancer than expected in a family. So it might be that multiple people in the family, just like in this family here, we're seeing 4 women in the family having cancer. That could be a clue that maybe there is a hereditary explanation for this. There might be multiple generations of cancer. So in this example, you're seeing in each generation, there is an instance of cancer. There might be younger ages of diagnoses. So we're seeing a breast cancer as young as age 38, which in the world, if we're thinking about breast cancer, typically we kind of have an arbitrary cutoff of age 50. So anything under the age of 50 we consider to be a young breast cancer. And then we're also looking for rare types of cancers. So ovarian cancer, pancreatic cancer, a metastatic prostate cancer are types of cancers that, you know, we don't really see very often in the general population. And so if we see even one of those in the family tree, that might be reason enough to consider getting genetic testing. Another example that I didn't include in that list is male breast cancer. If we see breast cancer in a male, that is also one of the types of cancers that can prompt to consideration for genetic testing. Also then, you know, seeing a person who has more than one type of cancer. So we don't quite see that in this family tree here, but sometimes we might see someone who has, you know, both a breast and an ovarian cancer, or another 2 different types of cancers. And that can be reason enough to consider genetic testing as well. And then, of course, as a genetic counselor, one of the things we do is also see, are we seeing any patterns of cancer in the family that we might expect to go together in certain syndromes? So an example is breast and ovarian, like in this family. There is a specific syndrome that where we see breast and ovarian kind of go together. And so that's something that a genetic counselor you meet with would be looking for as well. If I'm going through this and you're thinking, there's someone I know or someone in your family who, you know, maybe fits some of these clues, you might benefit from a genetic counseling visit. And so at the very end of this slide, I do have the website for our genetics clinic if you're interested in meeting with a genetic counselor on our team. So it's also probably worthwhile to discuss then what genetic counselors do. So I kind of think of us as being kind of at the intersection of being a healthcare provider, an educator, and a counselor. So part of what we do in our session is we'll review your personal and family history to assess what your risk is, and we communicate that risk to you. We tell you, based on your personal and family history, how likely it is that you might test positive or what we might be suspicious for if something were to come back positive. We'll discuss the benefits and limitations of genetic testing with you to allow you to make an informed choice of if you want to go forward with the testing or not. We then make sure we are ordering the appropriate test for you. So testing might not be a one size fits all. We might want to make sure based on your personal and family history that the appropriate sized test is being ordered for you with the appropriate genes included in it. We will interpret your results. So when the results come back, we communicate those results to you. We are also trained to provide psychosocial counseling. As you can imagine, in some of these sessions, a variety of feelings can come up for people. And so we are equipped to kind of handle those just kind of initially in the session as well. We then also, of course, work with other providers to ensure that any appropriate follow-up care is set up. So depending on what the results are, we just kind of make sure that if there's any follow-up recommendations that need to be made, that you're set up with the appropriate provider who can make those. And I guess one of the questions that comes up, and is a question I get asked at the beginning of my session usually, is what is even the purpose of this? What is the purpose of getting this type of genetic testing? And a kind of an easy way to just say it is it's just to allow for screening, prevention, and risk reduction. And to help kind of illustrate that, I think it can be helpful to run through an example. So let's take the example of hereditary breast and ovarian cancer syndrome. This is one of the most common types of breast cancer related syndromes, one that you may have heard about in the media already. You may be familiar with someone who has a mutation in one of these genes. They're called BRCA1 and BRCA2, but also called BRCA1 and BRCA2 in the media, if you may have heard about them. Angelina Jolie had a BRCA1 mutation that, you know, the media kind of, she had a lot of media coverage around it, and I think that's when a lot of people became aware about these genes. We actually call it the Angelina Jolie effect, the amount of people that started coming in for genetic testing afterwards. And more recently in media, we've seen Beyonce's father be a carrier, I believe it was, for BRCA2. So BRCA1 and 2 genes, just like all the genes we talked about earlier, as we mentioned earlier as well, we have 2 copies of each of these genes. So my little cartoon here is just an example of, you know, having 2 copies of each of these genes. Now, for someone who was born with one of those copies not working properly because of a spelling error or what we would call a mutation, that's someone who has hereditary breast and ovarian cancer syndrome. So what does that mean? That means that this person now has an increased risk of, if they're female, they have an increased risk of female breast cancer, of ovarian cancer. If they're a male, they have an increased risk of prostate cancer or male breast cancer. And then regardless of sex, they might have an increased risk of pancreatic cancer and a melanoma. As you can see, the nature of how our genes work, they can be associated with more than one type of cancer risk. So that's the kind of information you could potentially learn from getting a positive genetic test result. I always like to mention, like I mentioned earlier as well, having an increased risk is not equivalent to saying 100% risk. So the female breast cancer risk is probably the highest, it's not probably, it is the highest risk among this list of cancers for someone with the mutation in this gene. And we estimate that the female breast cancer risk for someone with the BRCA1 or 2 mutation is estimated to be a 50 to 80% lifetime risk, which means that 20 to 50% of people with the gene mutation will never develop breast cancer in their lifetime, but it's still a significantly increased risk compared to the general population's 12% risk of breast cancer. And so knowing that information is very helpful. And so this is where, you know, the screening and risk reduction comes in. So for someone who has come into our clinic and is tested positive for this gene, we can now offer them increased risk breast screening. So what does that mean? That typically means instead of just doing breast mammograms, we might now also add in breast MRIs for them. So we're increasing the types of imaging that they're doing to allow for early detection. So that in the event that, if hopefully not, but in the event that they do develop a breast cancer, we are detecting it at the earliest stage possible by increasing the types of imaging we are doing, making it a little bit more sensitive. Similarly, some women can use this information to make the choice of going through risk reduction surgery. So that is kind of like what Angelina Jolie did when she had a BRCA1 mutation, is surgically remove both breasts. And that is an option available on the table for women with the BRCA1 or 2 gene mutation as well. The ovarian cancer risk typically is dealt with by, you know, we recommend a risk reduction surgery. So what that typically means is after a certain age, we try to get it as close to natural menopause, but after a certain age, depending on what gene the mutation is in, we might recommend having the ovaries and tubes surgically removed. And the reason for that is there's no good form of screening, unfortunately, for ovarian cancer. So that's what the recommendation is, and it's a pretty drastic risk reduction of ovarian cancer risk. And then for the rest of these, there's various forms of screening as well. For prostate cancer and male breast cancer, there's some screening available for males. So prostate cancer typically just involves PSA levels, which is done through a blood draw, as well as digital rectal exams for males, usually starting at around age 40. For male breast cancer, typically that just means males who carry the gene mutation will be recommended to start getting chest wall exams after a certain age. You'll notice I put a question mark next to screening for pancreatic cancer, and that's because with pancreatic cancer screening, it's still what we consider to be investigational in nature. So we typically are only really recommending it for people who have not only a mutation in one of these genes that increases their risk of pancreatic cancer, but also who have a family history of pancreatic cancer. And so this is a great example of where, you know, these recommendations are not a one-size-fits-all. We typically, part of when we're meeting with you, we're taking into account your genetic testing information, your personal history, and your family history to help guide your care. And that's why you would typically meet with not just myself or like a genetic counselor, but oftentimes you might also be meeting with a physician in the event that you tested positive to talk about recommendations specific to you. And then with the melanoma, screening typically just involves skin exams, which is not very different from what we'd recommend to the general population and to use sun protection, of course. So one question I get is, what does the genetic testing involve? You know, how do you administer that test? So what we typically do is, you know, in the session after the patient has provided consent to testing, which I should add, they are also welcome to choose not to do testing. Meeting with a genetic counselor does not mean you have to do testing that day. But you know, they make their informed decision of whether or not they want to pursue testing. If they provide consent to testing, then typically either a blood sample or a saliva sample is collected from the patient. Right now, I can tell you most of our visits are being done virtually due to the pandemic, so we've relied a lot more on saliva samples, whereas previously when we were on site seeing patients, we had a phlebotomist, so we typically just be doing blood samples. So that can be different depending on the setting of the clinic. Then oftentimes that sample is sent to a lab that performs the testing. A lot of times the lab might be external to the hospital, so it might not be an in-house test at Dana-Farber. For example, our tests for the most part are sent to an external lab, actually out in California for the most part. And then the results, they take about 3 to 4 weeks to run the test at the lab. Then they get returned to a genetic counselor, and the genetic counselor will give you those results over the phone. Another thing I thought I'd kind of give you an analogy of what does the genetic testing process kind of more technically look like. You kind of think about it like a spell check. So let's just say, you know, like I mentioned earlier, our genes are kind of like these sentences or words that are spelled out. So let's just take this example of an arbitrary gene here that spells out "the cat ran over the mat," right? That's how it should normally be spelled. That's what, you know, a normal working copy of the gene would typically look like. What can happen, you know, if someone was born with one of those copies not working properly, or there was a mutation, just like here, you can see instead of it saying "the cat ran over the mat," one of the copies is now saying "the cat rat over the mat," which is not the same thing. That is what we would call a mutation. The genetic testing, what it's essentially doing is it's a spell check. So it's kind of just going through each individual letter in the gene and seeing if it is like what they would expect to see there, or if it is different, and if so, is that actually you know, harming or taking away from the function of the gene? Is it losing its meaning? And that's really what the lab does, is kind of analyze that information, give that back to us, and then we give you those results. The other thing that is worthwhile to mention is genetic testing has evolved a lot over time. So back in the day, we were, you know, maybe around 10 years ago or so, it was not uncommon to just test for BRCA1 and 2. Sometimes people called it even the BRCA test. But we've kind of moved away from that. So now there's different options and in terms of how wide we can kind of, if you may, cast our net in doing the testing. We call it now multi-gene panel testing. So we're looking at multiple genes at the same time quite often. And so one of the questions that comes up is how wide should we be casting that net? And that's a decision that a genetic counselor works with you to make in terms of deciding what is the best test for you. I can tell you, just to kind of briefly go over this, as sometimes there are some panels that are designed to be kind of more specific to a cancer type. So there might be a panel that is designed to be comprehensive for all the genes associated with, say, breast cancer. But then there might be panels that are designed to be comprehensive for some of the common hereditary cancers. So that might include genes that are associated not just with breast cancer, but also with gynecologic cancers and gastrointestinal cancers. That includes things like colon cancer risk, for example. And that's actually a common panel we use because that's often a panel where even if there's an unexpected result, it might have implications for your care. So, even if, let's say, we do learn of a moderate increased risk of colon cancer, even though that was unexpected, it might mean that we recommend you now do colonoscopies every 5 years instead of every 10 years. And so our thought is we'd rather know that information than not know it. And that's part of the reason why, at the very least, we typically start with that common hereditary cancers panel. But I will tell you that I've made exceptions and I've gone a little bit smaller for people in the past. And again, that's part of where it's my job to also assess what's best for the patient, how much is the patient comfortable knowing, and all of that. And then, of course, there are the expanded panels as well. And these are panels that might include a lot of the newer genes that we might not really know too much about. It might be more comprehensive for types of genes that are, associated with other types of cancer risk that might not have been included on the smaller panel. And so sometimes what prompts us to go with those expanded panels is if there is some of those obscure types of cancer risk that we're seeing in the family that the smaller panel might not be comprehensive for. Other times I have people come in that tell me, you know what, I want to know as much as I can know. I'm an information seeker. And sometimes, we then talk to them about the expanded panel and we might go for that. But that kind of depends on, again, you're meeting with a genetic counselor and they can decide what's the best test for you. So I'm going to stop myself there. I know people might have a bunch of questions, or I'm happy to kind of go delve a little bit deeper in something if you wanted me to go over something again. I did include the website for our clinic. You can also just find us if you just kind of Google DFCI cancer genetics. Hopefully it should pop up as one of the first few links. And you're welcome to meet with the genetic counselor on our team if you would like to, or if you think that it might be worthwhile for you to do so. And yeah, I'll kind of leave it at there and help answer any of your questions.
Thank you so much, Fatima. Can you hear me?
Yep, I can hear you.
Right? Okay, good. Yeah, so there's one question in the chat, and then I think after that, feel free to unmute yourself if you have a question or type it in. So Diana is asking, does Medicare, regular Medicare, cover genetic testing, and what does it usually cost?
That's a great question. So Medicare, like a lot of other insurances, does typically lay out their coverage criteria. Part of what happens when you're meeting with a genetic counselor is they can help address that question a little bit too. I will tell you though that one of the things it's part of the genetic counselor's job to obviously look at that information as well and tell you up front whether they think it might be covered or not. But also a lot of times the labs that we're working with are handling a lot of the billing. So even if, let's say, we might know that Medicare might not cover your test, there might be an option to still pursue testing through self-pay. As genetic testing technology has evolved, testing has become a little bit more, like the prices have gone significantly lower over the years for self-pay price. So just as an example, some of the common labs we use, their self-pay price is $249 out of pocket. So even if you don't meet coverage criteria, there might be an option for you to still pursue testing through, by paying out of pocket. That's a great question. So a common misconception I will say that comes up is, or people, what they might not know is that these genes can be passed on through males as well, even if the cancer risk predominantly is a female cancer risk. So, you know, what we typically will say is, you know, if there's any concern regarding the family history or such, you're welcome to come in. What will happen is we'll draw out a full family tree. So for example, in your case, you know, if you don't have any cancer history for yourself, it might not be something, it might be low risk potentially to carry a mutation. But if you're concerned about your father, your children's biological father side of the family, the biological father can come in and get a genetic counseling visit, undergo testing, and then if he tests negative, then we may or may not recommend genetic testing for the children at that point. If, you know, because if he tested negative and that's where the cancer concern is on that side of the family, then we wouldn't expect the children to then test positive at that point.
Can you just explain the, what do you call it, cascade testing? Like, why would you start with the father and not the daughters?
That's a great question. So typically what we would like to do, ideally, if the person who has the cancer of concern is available. So actually, let me, you know what might be helpful here is this little drawing here. So let's just take this diagram here. You know, can you see my arrow?
Yeah.
And my mouse, I guess. Okay. So as you can see, there is an arrow pointing here to this female here who does not have a cancer diagnosis. That arrow typically means that that's the patient that's coming in to see the genetic counselor. Now, in a case like this female here, even though she's coming in to get testing, she's actually what we would call an uninformative person of the family to get testing. And I can explain why. So if this lady here, I don't know where my arrow just went. Oh, there it is. If this lady here gets genetic testing and she tests negative, meaning we did not find a spelling error or a mutation in the BRCA1 or 2 genes or any of the genes we'd be suspicious of that explains that family history, we don't know that she tested negative because this family history is not hereditary, or she just did not inherit that gene mutation. And that's why typically the first person you want to start off with is someone who has the cancer of concern. So in this family case, we would recommend that her mother come in for testing ideally. But sometimes we know inevitably the person who has the cancer of concern might not be available. Whether that might be because they've passed away or they just might not want to do testing, they might, or you might not have a relationship with that person, regardless of what that might be. And in that case, we can then try to see who the most second appropriate person would be. So for example, you know, like the question we got earlier, instead of testing the daughters directly, the father is someone who would be more closely related to the people who had cancer. So instead of testing the daughters individually both times, or that might be 2 people then that need to get testing instead, if you just test that one person, then if they're negative, we don't need to test both of those people. So we're also trying to be efficient in the way that we approach who should get testing. So that's part of the decision making around that. So that's a great question, and thank you so much for sharing some of that personal and family history. So a couple of things. One, you know, we talked, one of the things we mentioned is that genetic testing technology and our knowledge in genetics evolves a lot over time. So if you had testing back in 2008, it would be recommended to kind of potentially pursue updated testing, because I can tell you if you had testing in 2008, the testing now is a little bit different. So that if you still have your information or your letter, it probably has the number on there to call. And we're doing virtual visits right now, so you could stay in the comfort of your home and get a genetic counseling session, get a saliva kit sent to you and get a new test. You could call your genetic counselor or whoever's contact was on there and ask them specific questions to your case as well. But yeah, we are seeing people, and that's why even now when we send out our letters, we typically put a little blurb on there saying, especially in the case of a negative genetic test, we'll typically say, stay in touch with us every few years or so to see if there's any updated testing options available. That's paraphrased, obviously, but I will even sometimes tell people to just put me in their Outlook calendar every 2 years or something to just reach out to me, see if there's any updated testing recommended at the time. And so it's not uncommon for us to see people coming back again, maybe 10 years later, 5 years later, whatever it might be, to come for updated testing. And sometimes, yes, that updated testing can identify a mutation. But also, I'll say even now, sometimes we do testing, we see a family tree that does look pretty suggestive of a hereditary, of a hereditary cancer syndrome, but we don't identify a mutation on our genetic testing. And some of the possible explanations we say are, one, again, our technology is limited. So maybe there's 5 years from now, 10 years from now, a gene we discover that'll explain that family history that we're just not seeing now. Sometimes we might even say that maybe people in the family who had cancer their cancer was explained by a mutation, but maybe your instance of cancer was sporadic in nature. So one of the things we talked about earlier in this presentation was that most cancer is sporadic, meaning it's not due to a hereditary cause. But that's part of the reason why, and there is a familial category here as well, where we might see, multiple people in the family with cancer, but we haven't identified a genetic mutation in the family. And one of the possible explanations there, like I mentioned, is there could be a gene we just haven't discovered yet. But that's part of the reason why we don't ignore family history. And so part of meeting with a genetic counselor, and oftentimes we also have you meet with a physician on our team as well, is that they can take not just your genetic testing information, but also look at your family history and personal history to make recommendations. So even if someone tests negative on genetic testing, or let's say for your daughter's case, for example, let's say that she, if your testing was negative, even updated, and there's no mutation identified in the family, sometimes just based on the family history alone, one might be recommended to undergo extra breast screening or something. And that's part of that, and that's because of that exact reason that there could be genes we've just not discovered yet. The good thing is breast screening works, so it is a pretty effective form of a screening tool we have. But yeah, I hope that helped explain that a little bit. Great question. So I oftentimes, when I'm talking to someone, I'm talking to them about the genetic testing piece of it. Usually our scheduling team is the one that can talk about coverage of the actual visit or not. Okay. It's varying rules depending on the insurance and stuff. And I'll tell you, I don't really know much about that. But our scheduling team is usually knowledgeable about that. They can look at your insurance and see whether or not there's a copay or anything for the visit, and can help give you a little bit more information on that. My understanding as far as the genetic counseling visit itself is that I think Dana-Farber doesn't really bill that high, is my understanding. Don't quote me on that. I probably shouldn't say this because this is recorded, but I think that it's the fee for the genetic counseling itself would be a good question to ask the schedulers when you're calling to get scheduled. They would know better.
Okay.
So for now, we're doing a lot of virtual sessions because of the pandemic. We weren't doing them before the pandemic, but because of the pandemic, we've moved to virtual and hope to ultimately go back to in-person. But for now, if you guys wanted to make use of the virtual, you could possibly try to get an appointment sooner rather than later. But as far as the testing piece of it, that's where we're mostly using a saliva kit, especially for people who aren't coming into the hospital for a blood draw anyway. In some cases, we see patients who are coming in anyway, and so we might have their blood be drawn. But if you're not planning on coming into the hospital anyway, we'll just have the lab mail a saliva kit to you, you spit in the tube and mail it right back.
There's a question in the chat I don't want to miss from Nancy that said, what is the usual age for doing testing? Is there any upper age limit?
That's a good question. I'll say in our adult clinic, we're seeing people over the age of 18. There is a separate clinic we have for children in the event that children need to get testing. For the most part, for most of the genes that, especially with BRCA1, as we talked about, and BRCA2, most of these have adult onset risk, so we don't test children for the most part. But there are some syndromes where we might want to test children. But as far as the upper age limit is concerned, technically there's really no upper age limit. I think it's possible if you are maybe, let's just say you're 85 or up. It's possible that the results of the testing might not necessarily impact your management at that time. So an example being, if there's a breast cancer risk we identify, one of the common things we do for breast screening is to include breast MRIs. And part of the reason for doing that is because our breast density can be pretty high, especially in younger women. Over our lifetimes, breast density decreases, and mammograms aren't very sensitive to highly dense breasts. And so that's part of the reason why we add in MRIs to increase the sensitivity. So someone who's 85 that might have pretty fatty breasts, there might not be really much of a benefit to adding in the breast MRI as well. So it's possible that the results of your testing, even if you tested positive, might not really change your management by yourself, but you might be we talked about the informative member of the family to get testing. You might possibly be the informative member, and that might be a reason for you to get testing. But that's where, one of the things I mentioned earlier in the presentation, which might be worthwhile to mention again, is meeting with a genetic counselor does not mean you have to get genetic testing. Typically, you can meet with a genetic counselor and they'll help make the best decision for you. So if there's any reason for you to maybe not do testing, or someone else in the family would rather benefit from testing, that's part of the thing that can be brought up in the session as well. That's a great question. I'll just mention that the 85 number was totally arbitrary. I just kind of picked a number out of thin air. But I would say that in terms of recommendations for when to stop the screening and all of that, like you mentioned, one of the considerations, of course, is for, gadolinium toxicity, kind of being a little bit more technical, but that's one of the dyes that's used for the MRIs, that's under study, of course, to see whether or not there's any toxic side effects of that potentially. That is all part of the reason why we typically have individuals meet with a physician on our team as well. So I'll mention that it's definitely outside of my job realm to make any recommendations around when to start or stop the MRIs. But that would be a good question to bring up to your doctor. And if you would like to be seen at Dana-Farber, we have physicians on our team who could answer that question too, but I unfortunately can't. I think it's like a case-by-case basis too, right? So in your case, for example, like you mentioned, you might have more dense breasts, and that might be a reason why someone might consider to continue MRI screenings as well. And so that's where a lot of these decisions aren't a one-size-fits-all, and they're made based on looking at your personal and family history as well as your genetic testing information.
Let's see. I have a question. I was just wondering if you could talk a little bit about, besides breast cancer, like you're using the word syndrome, like what are other cancers that you are able to give predictions or probabilities about?
Great question. So, with the world of genetics, we're obviously learning a lot. And besides BRCA1 and 2 or hereditary breast and ovarian cancer syndromes, there are many other hereditary cancer syndromes that we test for as well. Another common one in the world of genetics in terms of hereditary colon cancer, is the most common hereditary colon cancer syndrome actually is what we call Lynch syndrome. So that's an example of a cancer syndrome that is associated mainly with 3 different types of increased cancer risks, predominantly colon cancer risk, of course, but then also there might be increased risks of ovarian and uterine cancer. There can be other increased risks as well, and typically that's something we go through with individuals that we might be suspicious for or who may test positive for Lynch syndrome. But then there's others as well. There are some syndromes that are associated with an increased number of polyps on colonoscopies. So some as severe as having kind of what we call polyposis and a carpet of polyps, where someone might have so many polyps in their colon that you can't really even remove them through colonoscopies. Whereas there are some that might just be more polyps than we would expect in usual, maybe between like 10 to 100 over your lifetime. So those are some syndromes we test for, and that can influence the number of colonoscopies you might be getting. And colonoscopies are, of course, one of the forms of screening that are one of the few forms of screening that actually prevent cancer, because in doing a colonoscopy, you're often removing precancerous polyps. And so we know that's certainly an effective tool to screen as well. There are other syndromes. There might be genes, so we might not necessarily call them syndromes, but there might be genes that have an associated cancer risk of just one really cancer risk that's established at this time. So an example, there can be a gene that can be associated with mainly just ovarian cancer risk. And so that might make a recommendation of, when to remove your ovaries and at what age that might be a consideration. And there are some syndromes that are associated with kidney cancer risk predominantly, some with thyroid cancer, etc. One of the things I will mention is also, because we can see a lot of different cancers sometimes in our families and stuff, it's worth noting, kind of going back to this chart right over here, is that most cancer is sporadic, and it's not because of a hereditary cancer syndrome. But 5 to 10% of the time, it could be due to a hereditary cancer syndrome. And so that's where, for someone to do a proper assessment, you would want to meet with a genetic counselor or get that assessment done. Sometimes your PCP might be a good person to just recommend based on the family history, if there's a reason to go see a genetic counselor. But yes, there's certainly multiple types of cancer syndromes. And like I mentioned, the kind of the upper end of the panels can be as big as 85 genes or such. So those are 85 genes that are associated with different cancer risks. So we could sit here all day and go through all of them, but I'll kind of just stop it at there.
Thank you. I have one more if nobody else does. Does anyone else have a question? Okay, so you talked about the testing changes. Like in Judy's case, she might want to redo it because the testing has changed, but like I just did testing last year. And so will somebody somewhere have my whole genetic code, and will that be like rechecked occasionally for new discoveries?
So that's a fantastic question. So one of the things we didn't really delve into this session, but that is relevant to answering that question, is when we do genetic testing, there's often 3 types of results that can come back. So it's not just positive or negative, but there's obviously a positive result, which means that yes, we did find a mutation in one of the genes that we looked at. There can be a negative result, meaning we didn't find any spelling errors, no changes in any of the genes. But we might find what we call a variant of unknown significance. That is a fancy way to say maybe or inconclusive. One example I can give you of that is, let's just take this example again here, right? We've got 2 copies of each gene, and let's just say arbitrarily, this is an arbitrary gene spelling out the word theater. Let's say that instead of this ER over here, it's spelled RE, theater. So that actually technically is still an appropriate spelling over in the UK, right? Or in Canada. So the meaning is not necessarily lost. Similarly, there are many changes in our DNA that might not necessarily harm the gene. They might just be completely normal variation in our DNA. So part of when the analysis is being done is to classify these different changes as either being a harmful change, like this one where it's no longer spelling out the word it's supposed to. Or it might be a normal change like theater with an RE, where it's just a variation, but it's still the same meaning. Or there's that unknown category where there might be a change in a gene that we just don't have enough evidence for today to classify definitively as a harmful change or a benign normal change. And that's what's called a variant of unknown significance, or just a fancy way to say inconclusive. And that's an example where the lab kind of keeps track of all the variants of unknown significance that they have. And they don't need new sample from you or anything, but they just have that in their database. And every 6 months or so, they're doing a review of those variants. And they're seeing, is there anything else added to the literature? Is there any new evidence they have to be able to reclassify that change? And if they reclassify it, which 90% of the times when it's reclassified, gets reclassified to a negative or a benign change, just normal variation. But when that is reclassified, then typically the lab will contact the genetic counselor, and the genetic counselor then contacts the patient, typically to inform them that it's been reclassified. But that's an example of when the lab might go back and look at your information again. Good question. So for right now, where we are still virtual, for some people, I have also been doing sessions over the phone as well. I think the primary preference is to do it via Zoom, but I recognize not everybody might feel comfortable with Zoom or whatever the case might be. So we definitely can still do over the phone calls as well. Yep. That's a great question, and that's part of the reason why typically what we do in the session is we draw out kind of the family tree like you're seeing here. So we kind of look to up to third degree relatives. So we're looking not just at the parents and the siblings and the children, but we're also looking at more extended relatives. And we do that because we're trying to see if we're seeing any patterns in the family that make it suspicious for hereditary cancer. I would say if you're concerned about your cancer risk in your family, you're welcome to still come in for a genetic counseling visit, and then you can get a proper risk assessment done. Generally speaking, of course, I've not seen your family history, because part of what we also do when we're taking a family history is we try to note down the limitations with family history. So we recognize when we're taking a family history, even though that's a great tool to assess for risk for hereditary cancer, we recognize that there are inevitable limitations of family history. So maybe people don't share their diagnoses with family members. Maybe people just have really small families. There's not a lot of family members. And so if someone had, so let's just say here, for example, if this person had 5 more siblings, would we have seen more cancer here versus them just having 2 siblings, for example? So there are multiple reasons why there can be limiting information just based on family history alone. And so in some of those cases, we might still say, well, testing is, we have a very low threshold of just saying, you know, it's still available to you as an option if you're interested in knowing your risk. Another thing that would be relevant in that case is the age of diagnosis. So how old was someone when their colon cancer was diagnosed? That can help, you know, make that decision as well. But also, you know, there might be other questions that your genetic counselor might ask you too. And like I mentioned, it might be that your genetic counselor might say, well, you know, this is kind of a low risk, a low threshold, and so maybe insurance might not cover it either. But testing is still available to you if you want to do the out-of-pocket $249. But so we're not gatekeepers of genetic testing. We'll still allow you to do it if you are just someone who's curious and wants to know your risk, even if you do have a low risk family history that insurance might not cover testing for. But you know, it's one of those things where to do a full risk assessment, we would typically draw out your family history. We would look at your personal history and ask you questions about your personal history, and then make that assessment.
Okay. Any last questions? We have a lot of information to digest. And I want to say thank you so much to Fatima for presenting it so clearly and for being here tonight and for sharing this with us. So if you could actually put it back on the slide with the website, that would be helpful if
Yes.
folks want to get in touch. Whoop, there it is. So I think that will be the end of our session tonight. Thank you so much, Fatima.
Thank you. The pleasure is all mine.